introduce a gentleman who has coined the term. And Devon Smith is the head of BOSS, and he gives us our good wishes in this meeting over here. My topic is microendoscopic micro ECIRS, which is basically combining micro PCNL with ECIRS. So with that, I'll just start my show. May I know everybody can see my slide? Okay. So basically, I feel that we've gone through an amazing, revolution or evolution, or you call it re-evolution of real calculus. And I feel that we are going through these three stone ages. We've evolved from the Paleolithic stage to the Neolithic stage, where people used to talk about only ESWL, and now they're talking about using artificial intelligence in PCNL. And so let me invite you to my little galaxy, and we're not talking about our galaxy, but we're talking about the galaxy of PCNL. And like Dong rightfully said, we've gone a long way, we've come a long distance, and we are now talking about mini micro and micro, and we're not talking about mini skirts and micro skirts here, but we're talking about PCNL. So with that, let me share with you what I think is probably going to be something which we will be seeing more and more in the future, as well as my journey towards it. And this is the first thing which I'm sure all of you, when you look at this paper, it makes you go, oh my God. I mean, we've all seen this, where we know that making the size smaller is good, but then it didn't really show any major effect in the pigs. Neither did it show anything in the cadaver kidneys. But when you have an instrument inside these holes, the smaller it is, the better, because if you have a bigger instrument in a bigger hole, you may cause more bleeding. And I think that was the basis, the paper which actually made us evolve PCNL. And the evolutions happened like you've known, everybody knows: track size, technique of access, tubeless, non-tubeless, patient position, or even artificial intelligence guided. And I think this is a never-ending debate. I'm not here to justify that. But funnily, if you actually Google it, even Google is not able to decide, because the number of research topics that come up about the same. And it's not something new. This has been going on from 1976, when the first paper on PCNL came out, to Professor Valdivia. I take the opportunity to welcome him to our forum. He's over here with us. And in 1987, when he came out with the first paper, it was quite a revolutionary paper, but unfortunately, people were just talking about prone PCNL. And I think that was probably because if you look at it from 1988 to 2008, most of the publications were only talking about the problems associated with prone PCNL. And we had all got into our head that it provides a posterior puncture in a posterior calyx with the Brodel spleen. And I think these were some of the things which were ingrained into all of us when we were doing that. And well, the CROW study was great. The gentlemen involved in that, they also gave us many other important data, apart from just the fact that prone PCNL is better. They also devised surgical complexity scoring systems. So what was the disadvantage in supine PCNL? Most of the things I've just highlighted them over here. The important part was that they said upper pole calyx can be more challenging and there's limited space. But we have actually gone through a revolution in endourology, like I said, because everything has changed. And this change has happened in these 2 decades. And I think the fact that we now have miniaturized instruments, we are talking about, like Dong also pointed out, tailored approach. And this actually led to a brand new classification of the PCNL in terms of so many names, whereas what we really were looking to see is just miniaturize them to the smallest possible diameter. Came to micro PCNL, which is 4.8 French, which will basically be my focus of interest. But before that, this led to an explosion of a lot of papers which now started talking about different sizes of PCNL. And at the same time, supine PCNL became a possibility. So, from 1978 till then, it took a long, long journey for people to start thinking of supine PCNL. And it was great because in the early 2000s, people now started doing a lot of research. They started saying it's less operative time, it's higher stone free rate, it's better. And this was all good news. So I think Prof. Valdivia, from his initial paper, which he shared with me in one of my presentations when I had made earlier, from then to now, 78 to 90, he was still trying to convince people that this is better. And it's only in the 2000s that he came to know, which is why I think now he's relaxing and he takes his holidays. And he's smiling because I think we've come a long way with supine PCNL now. But there were so many positions which also evolved with this because everybody was trying their best to see what is the ideal way that we can actually get a good stone-free rate, a good access. And I think with all this, the problem came, I feel supine PCNL is like Kama Sutra. And it's a bit annoying at times because you don't know which one to choose. I actually asked him, and he said, yeah, I think if you read the Kama Sutra, maybe you'll find some other supine variant. And I'd just like to share my evolution. I was I was trained to do prone PCNL, and it took me almost 4 or 5 years to understand that supine PCNL is a better option. So I would thank Professor Arthur Smith, who actually gave me a little more sound training, and I also like to thank Dr. Guido, who gave me a sound shelling and said, "What are you doing prone? Shift to supine." But what really motivated me was this gentleman. Most of us know Professor Santosh Kumar. I think he's with us too. When he came to Singapore, he did, and I think he's got the fastest fingers in terms of a prone mini PCNL. So that was just very inspiring to see that. But really, what inspired me to go further was a wonderful presentation by Professor Janak Desai, who also visited Singapore. And he presented his paper on ultra mini PCNL, and he's shown us evidence from 2013 to 2016 that size actually miniaturizing is probably the better way forward. Not necessarily the best way, but definitely the better way. So I went back and read, and then you realize that Dr. Mahesh Desai has already published it in 2011 on microperk, which is nothing but a 4.8 French all-seeing needle. And would you imagine that what was done in 2011, and this is 2020, we are talking about it in the 9 years, it's just the same company which is really patronizing microperk. So which goes to show that maybe it's not the best option, but it was good that Professor Savnis, who is now heading Nadiad, actually presented a paper 2 years later to show, hey, it can be done. And it can be done in ectopic kidneys. It can also be used for bladder calculi. They had this mini microperk modification where you can upsize it on table. And it was fantastic. In the Indian Journal of Urology, when they came out with this publication, I was quite happy to read this. And it inspired me to sort of consider, can I do more? And I call them the gods of endourology because if you look at literature, 75% of that is through them. And they have patronized every single modality that you can probably adapt, as well as every single position that you probably want to adapt. But 2008 to 2016, at the same time, saw a fantastic growth in RIRS, and suddenly everybody was an RIRS warrior. And it was the RIRS was a popular choice. So it's just ideal that if you have RIRS, which has grown in popularity, easy to do, replicable, and better understanding of anatomy, and PCNL, which has become miniaturized, then why not we just consider doing both, which is perfect because Professor Skofane Cesare introduced the concept of endoscopic combined intrarenal surgery in 2011. And this is a great video of his if you get a chance to see it. It highlights a step-by-step way to do this. But we are still using mini supine ECIRS. We haven't really done anything more beyond that. This is a good book by him. I really advocate reading it because it gives you very fine tips about it. And I thought to myself, okay, I've understood how to do an RIRS. I know how to do a PCNL and different. I had to mount the curve to go up on the difficulty in RIRS. And I had to mount the curve down to understand how to do a PCNL with a smaller puncture. And I think this is the crux of doing a micro ECIRS. It takes a bit of learning. It takes a lot of understanding, but I think it's definitely a good option. And I'm grateful to both these professors because Professor Zhang, as far as I know, does the super mini PCNL, and he does them sometimes even in blocks, nerve blocks. And patients actually lie down, they get a block, he finishes the PCNL, he sends them home. And then I went over to Beijing to learn from Prof. Li Jung on the concept of micro PCNL. And he actually told me, he said, oh, we don't do it under fluoroscopy. And why don't you do RIRS without fluoroscopy, ultrasound guided? I said, wow, I'm in the right place to learn new things. So with that, let me introduce you to what I learned and what I think is a great option. So basically supine micro ECIRS. Again, you can do it in prone, you can do it in supine. I'm going to try and show you tips and techniques of both. This is the, on your tray, you're going to find this when it comes out of a set. It's usually packaged like this from Polydiagnost. And they give you all these little instruments which you need. And the best part about micro PCNL, they themselves claim you view micro, but you see in macro. And I think that is the reason why I feel the resurgence of micro PCNL may happen. And if I put my finger next to it, this is absolutely, my finger is a little more stubbier than the micro PCNL or the mini PCNL sets. But definitely I would look at micro PCNL as a great option. And if you look at it, when you mount this into a body, this is exactly how you're going to be seeing it. And sorry about that. Okay. And then if I look at this one, they've done a very good thing that they've actually taken off the weight which comes with the camera, made it adaptable to any system, given you a fantastically, very interesting fiber, because it has more than 10,000 lumens. That means it's really bright, really good. And maybe it's a bit too long, the needle. Some people say you could reduce it. I think the company may consider that. But this is exactly how you start off. What I want to show you is the versatility of the procedure. Okay. And now the first thing here we are doing is we are doing, as you all know and we all know, supine PCNL in triangulation method. And the difference in this is I'm not really putting a needle first, which is a 16 gauge needle. I'm going straight with the PCNL, which is provided in the set, and I'm actually puncturing and then going in over here. This is advanced endourology. You could do it first with a 16 gauge needle, put a guide wire, and then replace it with this. But the 4.7 French needle is so robust, you can actually go directly and puncture. And after you puncture, you just take out your fiber, and then you put your attachment to it, and you're all set to start. So it's a straight go. From the word, you go inside the system. And for those of us who like ultrasound, I just wanted to show this puncture. You can actually see the needle coming in beautifully. It's because of the way they've designed the needles, the grooves. You can actually watch it coming, and you can see the groove of the needle. You can see the needle entering into the calyx. So, like I said, use a 16 gauge. You want to do it directly without a 16 gauge straight with the needle. You need to use an ultrasound. Great, you have options available to you. And if you think that this was good, I think it gets better. Because over here, this was where I'm showing you in prone when I was learning with Prof. Lee Jun in Beijing. It is directly under vision. So it's just like a fascial dilator, watching it. Now, interestingly, this little syringe is all that you need, 1 cc to inject as you do a fascial dilatation and go into the kidney. And when you do that, suddenly you'll realize you're inside the kidney, and that's perfect. That's it. In experienced hands, it takes maybe about 10 to 15 minutes to get into the system. And they do about 200 PCNLs a month. And it's no jokes. They do it from babies to adults. So I think they have great experience. It does take a bit of learning if you want to do it with a direct fascial dilatation, but the learning is maybe 10 to 15 cases, not more than that. Now, this one is just to show you that the same principle of fascial dilatation to enter, I'm actually seeing the exit tract. And the view is beautiful. I come out into the perinephric space. I can see the fat there. And if I lose my tract, no worries, I can go back inside. So I don't have a guide wire over there. And this is the best thing about this needle, is that it keeps a very clear plane. And to the next slide. Now, over here, so again, we are trying to show you that we can further use an ultrasound and a direct vision. So this is a combined opportunity to use the ultrasound. What he advises and what we also try to do sometimes is we take the needle up to the edge of the kidney. We don't go inside the kidney directly. We stop over there. We've done the fascial dilatation, which has brought us to the edge of the kidney. And then this needle has the option of giving you a direct vision. And the rest of it, you enter under direct vision. This little instrument, which is basically a tubing with a syringe, is key. And I just wanted to show you here. And sometimes you may wonder, oh, what about bleeding? Yeah, obviously, I mean, you're doing a small puncture. There will maybe a bit of bleeding. You can see the fat, which is basically the fascial dilatation as you're going through. There's a little trickle of blood over there. No worries. Take 1 cc or 2 cc and flush it away. And you keep doing that, and you keep progressing. And you look at his hands, he's just moving the needle around and round and round, and he's going inside. And soon he's inside. And of course, for those of us who are skeptics about this, and we are not too sure, you always have the option of direct vision, which is basically where micro ECIRS helps you. You watch your puncture coming in, and you see the needle coming in so beautifully. You have the opportunity to make sure you don't over puncture. You have the opportunity to make sure you don't perforate into the system. You have an opportunity to try and make it transpapillary as it gets. And I think that is the golden opportunity provided by a microport needle. And this is to show you that once your needle is done, I mean, your entry is made, you actually use the very same laser settings to do anything that you want inside a kidney, what we do with RIRS, and the vision is exemplary. I'm breaking the stone here. I'm trying to fragment the stone over here. I'm using popcorning over here, and I think I can do all. And you see, the endoscope is positioned for me. I'm actually showing the needle, which is close by. You have to be careful. There's no doubt about that. But if you're not, but I think you have to be careful for every single procedure, even a cystoscopy, you got to be careful. So everything has a learning curve, but I think this is appreciable to know that the vision is really good and you can really do a good job. I didn't disclose, but yeah, I'm not being patronized by any company, and this is just an experience I'm sharing with you guys. The next thing, which most papers, most comments are made, is about intrarenal pelvic pressure. Even Dr. Dong showed us that the intrarenal pelvic pressure is a problem. And intrarenal pelvic pressure is the problem where MicroPort did not really become successful. But when you have endoscopic combined procedure, you have an access sheet. Now, what can you put from bound? If you are wanting to do a visual puncture, you need obviously a flexible uteroscope. But if you don't want, there are papers which show where they have used a 7 French ureteric catheter. They've used T10, which is a 10 French ureteric catheter. They've placed just the access sheet, the smallest access sheet there. And they've also, used flushing directly from below via a ureteric catheter. Sometimes, whatever you do, you can actually see a flush coming very nicely. Even the fragments of stones get washed out over here. And this can be a continuous pressure. The intrarenal pressure is low because you have water draining always. And I think ECIRS is good where you have an access sheet, because you can see such good drainage from, if I'm flushing it from above, a good drainage if I'm flushing it from below. My fragments are coming out on both sides. There's no question about it. And if you do have the equipment, great. What you can do is add a suction to your access sheet. You can add suction directly to the needle. You can use a suction access sheet. What that does is it brings down the intrarenal pressure. And by intrarenal pressure coming down, you are not theoretically and probably practically not putting the patient at a risk of sepsis or hemorrhage. And in my experience, I do have the fortunate opportunity of having all these toys to play with. So I think it's great. Yes, you can say it's a disadvantage that you need 2 experienced surgeons. No, we've done it with 1 registrar and 1 experienced surgeon, 1 nurse and 1 experienced surgeon, 2 experienced surgeons. It depends on the complexity of the case you're dealing with. It's a matter of how you train, who you train. And I think with this, that holds good for everybody. I'd like to point out over here that with Prof. Trax here making very clear statements about what your diameters should be, the same principle applies to endoscopic combined intrarenal surgery. Make sure that your scope and your access sheet is not missed. Make correct size for the correct scope. And when you apply suction, it actually allows a few other things. There's no stone retropulsion. And yes, if you do it practically, you'll realize that you apply the suction to your access sheet and you're having a pelvic stone, maybe a 2 or 3 centimeter stone, it just doesn't move. It's a very low grade suction. You can actually manually control the suction. And I find that it really helps. And by applying suction, the intrarenal pressure drops from as high as 30 to 2.7, which is perfect. I mean, that's perfect for doing any procedure inside the kidney. And this is something to show you some tips and tricks. We know that with ECIRS in general, even with micro ECIRS, you can pass the stone. You can enter into a diverticulum very easily. You can retrograde, that is from below. You can pass some device to dilate any infundibuli. We've used it also for an endoscopic balloon dilatation where the puncture from above is showing us and we are dilating the PUJ in a patient who had some pyeloplasty before, refused the surgery. So I think there are plenty of opportunities for you to use this device. This is something where when I was doing a fluoroscopy-less procedure and I couldn't really get my scope into the lower pole, I was a bit struggling. And my boss, who helps me usually, was telling me, hey, come, look, you can actually get your litho view into this area. And he was guiding me. So I was watching his screen and I was able to get it through. And over here, I'm showing you the a trick which I tend to use. I actually pass the access sheet itself into the through the infundibulum into the calyx where I have dusted the stone, and I actually use that like a suction device. And this is the very same principle which is being used by suction devices post PCNL, which are coming up in a big way as well. So I think with the advantage of watching what you're doing, which happens by doing a micro perk and the endoscopic combined procedure, you are very safe in ensuring that you're not causing any undue trauma. Let me just hypothetically give you a situation. I have a 75-year-old gentleman, and I've done a 2 centimeter, the CT scan shows me it's a 2 centimeter stone. And what would I have counseled the patient or the family in the era of ESWL? Probably it's too big, strange to say, and you know the story which goes with it. So in the era of PCNL or RIRS, which is right now where we are, I'd probably tell him, look, there's also the possibility of doing it this way, but there are so many other things that have to be accounted for, and it's probably 2 stages. So at this point of time, patient is like, okay, maybe I'm going to go for RIRS or PCNL. To the doctor, it gets complicated. Now, this guy's got so many comorbids, which is very, very common to see in, let's say, in a population like Singapore, which is geriatric, and the patient is fat. He's probably had some spine surgery, etc., etc. This is just general issues that come up. The family is just, really fed up because they've Googled, they've gone to a few consultants, and they don't know what to do. What happens right now is you can't do ESWL for sure for this kind of patient. You're also thinking to yourself, hey, should I do RIRS? Should I do PCNL? So I think that's an ideal case where why don't you tell them, let me just do a micro ECIRS, which is safer for you. I don't need to stop your aspirin. I don't need to stop your anticoagulants. It doesn't matter. Another case which is similar where I can show you a CT scan of a patient. And this gentleman had procedures done both sides. He's a rectal stone former. There were stones scattered here and there everywhere. There was a little stone in upper calyx diverticulum as well. Or a patient who's like this, who's really fat. In a supine position, he's an obese patient. It doesn't matter. This gentleman also had a cardiac issue. There was no way that I could put him into a position. So I took permission from him when I posted his photograph, and I said, hey, that's something which I need to show people, to tell you, to show them that some situations like these, either the case where multiple previous surgeries, patient was a recurrent stone former, an obese patient, or just this kind of case where you can see some fluoroscopic images showing you when we did a bilateral procedure, same sitting. This was a really funny anatomy. So I did this with the RIRS. Then I went ahead and did RPG, where I saw there's one diverticulum in the lower pole, and there's one diverticulum in the mid pole, and there's one stone in the upper pole. So I did a micro perk for him directly with a direct access, as I showed you, without some guided. Went in over here, cleared the stones. Took my flexible utoscope to incise the diverticulum, cleared the stones, and then I went up to the kidney and I did everything. And lastly, there were a little bit of stones which were kind of stuck, which I wasn't able to get out. So I guided my flexible scope into that, and I managed to clear them. Most of the micro perks, I don't keep nephrostomy tube. I put a stent inside. I just put a stent. I think maybe it just gives me the pleasure of sleeping. You don't really have to, if you're very confident that the surgery is well. You don't have to pre-stent every patient, but yes, if you have a stent inside, it helps. When I was in China, I realized they don't stent most of the patients except pediatric patients. They actually do is a stenting on table. The resident then flushes water, and you'll be amazed at how much of the water gets refluxes into the kidney. It actually distends the system, opens up the ureteric orifice. They give tonsillosin to everybody before that. So some tips and tricks which can help you also plan your procedures. So I would say yes, tailored management, like Dr. Dong said, is the key at this point of time. The advantages of this procedure is it can be done. It's supine. It's minimal anesthesia. We've done it in GA in our place, but it can be done, like Dr. Arun pointed out, even in regional anesthesia. If you're in the Professor Zheng's unit, it's only done with some spinal or sometimes within fascial anesthesia, as he calls it. It's very, very minimally traumatic. It's very fast. It's a single step. When you get experience, you don't need to put your 16-gauge needle, put a guide wire, then dilate and change. This is straight one shot, go inside. And you don't really need to stop aspirin, but if you want just 2 days is more than enough. It's good for bilateral stones. It's good for faster recovery. We send the patients home the following day. The analgesia is, we tell them you take a Panadol if you feel the pain. And the patients are very happy because nephrostomy tube actually is the main reason they have pain, more than your procedure. I'm sure all of you have the experience where put on a nephrostomy, the patient is a bit unhappy. So some of the great things which you can do with micro ECIRS. And a very important question everybody asks is cost. Yeah, this was a paper shown by Darren and team and also with Bhaskar Somani. The cost is basically what the company gives you, and this is the cost in their paper, was about 375 euros. it's not you have to remember that there is a disposable part and there is a fixed part, and the company actually will support you with all the joint or the fixed parts, which is basically not included in the cost, and you don't have to bear with it if you do a certain number of cases. In most places, they do that. Um, it of course brings down the cost as you do more and more, and the parts are very cheap. The important part to remember is that if you buy a PCNL set, you also have to spend money. You buy an RIRS set, you also have to spend money. So somewhere you decide, you want cost versus what's the best option for my patient, and you decide what could be the easier approach. I put this up only to say that in 2020, when you look at EAU guidelines, they only talk about endourology. They don't specify what. We take it for granted that this is mini PCNL or RIRS. But I think I'm hoping that with micro ECIRS coming up in a bigger way, maybe the guidelines which come up will probably bring that in as a treatment option. This is a book by Professor Kamal Zakaria, who describes the details of the procedure. Very interestingly, he's actually given this picture over here and says, maybe it's a rough guide. And to me, the company itself gives you, remember, two needle options, or an option to upsize your dilatation. You do the dilatation under vision. It's a single dilatation. You can upsize it to 10.5 French by just adding the extra sheet. You don't have to do anything more. It's very straightforward. And if you don't want that, because that's extra, then you can always get these fascial dilators of yours, which are quite cheap. Multiple companies make them, and upsize your puncture. And the Matiosa technique has been described and used very frequently, where they say you can jump from one size to the other size quite easily by a single step dilatation. And they have actually done, you can actually go from extra small to large or medium in just single step dilatations, easily done in supine and prone. That choice is totally left to you. But I think if you're going to do a micro ECIRS, probably supine is a better choice. And what does it really do? Basically, it takes away all the factors that are associated with hemorrhage and gives you a relief, because with this little puncture, small puncture, with the RIRS as a backup option for everything available, you can actually do a great procedure for the patient. So what was considered as a disadvantage in PCNL what I just showed you between the last 20 years, and which was still a bit of a consideration until recently, has completely changed. The perspectives have completely changed with micro ECIRS. Almost everything is now got a smiley face, because there are really no disadvantages with supine micro ECIRS. Maybe cost, maybe it's a large staghorn stone, and maybe your worry or your lack of experience to do it. But if you do it, I think you'll gain more confidence, and it's much easier to do. So according to me, tailored management is considering all these treatment choices: anatomy, the expertise, your location of the stone, what is your outcome expected, your reimbursement strategies, expectations of the patients, as well as decision taking, which is between you and the patient. You have to have a very good detailed discussion and document the detailed discussion for medical legal purposes. And I think that's what's tailored management. So it's your choice. We have so many choices today. My choice is the 4.8 French currently. There's enough evidence in literature which is coming up. This was the recent most paper which came this year, and it's promising. It's showing that it's doable. Prof. Sabnis actually showed it in 2013. It can be done in ectopic kidneys, and I think if it can be done in difficult situations and difficult anomalous kidneys, I think it's probably the way forward. I would like to just take this opportunity, because I know some of the professors have logged in, to thank them as well to give me all the training. This is my boss over here. You can see both the surgeons are sitting, and we're generally smiling through the procedure, and it's quite easy to do it. So thank you very much. I think it's been a great sharing session over here. We've had a long session, longer than we thought, and I think this is great. I'm happy to take any questions if there's anything that you guys want to. So, okay, there's Dr. Sanjay Khadni, who says the most cost-effective technique is mini PCNL, as you can use pneumatic lithotripsy. I agree that the pneumatic lithotripsy is great, but I think with the superpulsed lumium laser coming in with some evidence of 80 to 100 micron fibers of lasers coming in, the fact that the pneumatic lithotripsy ergonomically sometimes can be a problem. You can actually use them through your microperk with the 8 French or a 10 French, not with the 4.8 French. You definitely can get a great success rate. Trilogy, my friend Inatu, he's online. No, you can't use Trilogy. You can't use shock pulse at this point of time through a microperk 4.8 French puncture. But if you upsize it to an 8 French or 10 French, yes, you can still do it. Is there any other question over here which really needed? Okay. So I've also told that if you have bleed while puncturing the parenchyma, would I abandon? Look, the bleed with the micropoke is really, 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 really minimal. Only way I can say it is if you do it. You can abandon it, but I'll tell you why you don't need to abandon, because I'm talking about micro ECIRS. I just bring my flexible ureteroscope into another calyx and show you, but I have to be sure that that calyx will give me access to the stone. So the whole idea is to puncture only when you need access into a difficult stone or difficult place. My limitation is partial stagons at this point of time. I don't have experience more than that. I hope if I can, I think we will see whether that's an ideal way. But my thinking is, and this is my thinking, that if I can do two punctures, combining with an RIRS, such small puncture with an RIRS will not cause too much trauma to the kidney. Maybe it will be the best way that I can go there. And yes, a very, very important question John Abraham said. If I lost the track, I could even get back without a guide wire. Remember, you have a flexible ureteroscope below. You shine the light through that track. It can be seen through and through if you puncture the track with a micro ECRS. And you can put your guide wire through and railroad yourself back to safety. Yeah, I think I would like to thank everybody who has been over here. And I'd like to stop my screen sharing. Okay. Sorry, that was. I think I've addressed most of the questions. Once again, I'd like to thank the True team. I'd like to thank all the people who are logged in with us for the last 2.5 to 3 hours. Very special thanks to all the professors who joined in. I know some of them didn't want to be named, but thank you so much. All the eminent professors from India and overseas. I think we have about 20 plus countries, and across different platforms, we have 300 plus people who logged in. So once again, have a great day. Before I finish, I have to take one question on behalf of Dr. Lee. Karthikeyan, can you please unmute Dr. Lee Cocking?
Sir, to unmute whom, sir?
Dr. Lee Cocking.
Yeah,
the first speaker.
Yeah, got it.
Okay. Lee, say hi if you're unmuted. Dr. Lee?
He has to unmute himself, sir.
Dr. Lee, yeah, okay, yeah. Great. Right. Hi, welcome back.
Hi.
We took the questions from all the speakers. You have a couple of questions which came in. The first most important question Dr. Sanjay Pandey asked, which has always been at the back of my mind. If there has been a lot of fibrosis and you're doing HOLEP, let's say he's had trust biopsies before, or there's just fibrosis because of chronic prostatitis, is HOLEP difficult with such glands?
So far, I do not have much experience with those that have undergone TP biopsy during a HOLEP. But in the literature, it seems that even I've read cases of HOLEPs being done, even those that whereby people have done urolift. Obviously, the urolift got stuck in the mocellator. But it seems like the plane remains evident even after TP biopsies. Hello.
I'm so sorry, Dr. Lee. I got muted. Okay, that was, yeah, I think you have the enough experience to tell us whether that's possible. The other question which somebody asks is, do you think patients on long-term catheters with very big bladders, is that a problem when you do HOLEP? Let's say he's having a big bladders and on catheters.
I've done quite a few chronic retentions. Haven't done urodynamic studies on them subsequently, but they all seem to be able to void, and surprisingly, the Qmax increases with time. So I think that there is a return of bladder function once you get rid of the obstruction. So obviously, when patients are on, I think the only thing that definitely like neurogenic bladders or previous colorectal surgery which has injured the nerves, perhaps then the bed outlet surgery might not be the most useful. But for any man that grows old and has been voiding his entire life, and then it's usually the prostate that's giving a problem, and I'm happy to give it a go and see whether he can void after a HoLEP.
All right, and the last question is, when you do a staged HoLEP for something very big, is it a problem when you come back in to do the second lobe?
Unfortunately, once I've done one lobe, the patients all run away from me, and they usually void quite well. And 3 patients which I've done a hemi-HoLEP, the one all 3 declined, and then they just took 5-alpha reductase. They have got good flow anyway, so they declined this combination HoLEP.
All right, thank you so much for your very clear answers. The participants, the faculty, thank you so much. Thank you, everybody. We'll call it a day. We take